just resigned from the EMS for Children project here in Texas and took a position up in Washington, D.C., doing some other work along those same lines, so we wish him well. And he left, I believe, at the 1st of February. Is that when the 8th? So, but we will have our update because Dr. Shea's here for that, so we'll get to that in just a second. Wanted to start off on our agenda. I'm going to take a little liberty and move up the discussion on the Texas Medical Board revisions to the medical director rules. Dr. Greenberg said he would hang for a few minutes and share that with us, where that was and how that turned out. And we've been talking about that the last couple of meetings. So Dr. Greenberg, you want to go ahead and let us know?
I'm not used to being on this side of the microphone. And it is weird having the speaker behind you. I'm Bobby Greenberg, the chair of the EMS Medical Directors Committee. I don't know how much background y'all had on Texas Medical Board Rule 197. That's the EMS Medical Director rule. The rule change is complete. That rule change was multifaceted. I won't really go into the reasons why, but what has come out of it is there are initial educational requirements, which is either 12 hours or a course that is recognized by DSHS, which the Medical Directors Committee today agreed to send those recommendations forward to DSHS, or you can be board certified in EMS. Board certification in EMS, the first test hasn't even been given yet. That'll be in October. In addition to that, there's a 2-hour continuing education requirement for EMS medical directors. EMS medical directors will now have to, when they renew their Texas license, they'll have to say that they're an EMS medical director, which we've been asking for a long time. We see that a big step forward so we can identify who the medical directors are. And then one of the things that's probably been a little more confusing to people is the language in the rules says that an EMS medical director may not provide medical direction for more than 20 providers unless you get a waiver from the state. That definition of a provider is in there, but people tend to miss it. A provider is a transporting EMS service. So not a first responder, not a provider as in a paramedic or an EMT, but a provider as in a service. So the example we've been using is Houston Fire Department, with all their personnel and ambulances, is still one provider. And we don't know how many medical directors out there have more than 20. We don't think a whole lot. Last I heard, there were not any waivers requested. So that's my report, unless you want more or y'all have questions.
Any questions for Dr. Greenberg? And the waiver process is through DSHS, correct? Not the medical board?
Correct.
When do they go into effect?
They're already in effect.
They're already in effect.
They were published, I want to say, in November, or it was approved in November, and then it's been published. It's done.
So you guys need to take that. You need to get your medical director on that, because y'all are greater than 20, right? Yeah, the two that when we sat with the medical board that day and had that discussion, the two that I brought up were the ones in the Panhandle, where they have all those agencies north and south. But I'm sure they're in process on that.
Yeah, apply for a waiver.
Anything else for Dr. Greenberg?
Cool.
All right.
Thanks.
Thank you, sir. Thanks for coming in. Next on our agenda, we held a meeting in Houston last month to continue working on the suggestions for ways to address the large influx of ground providers in metropolitan areas, and to make suggestions to GTAC, agenda item number 1. And wanted to update everybody here on the committee, as well as those who have been coming to some of the extra meetings but not been able to make them all, or you came to the one in Dallas and not Houston, or vice versa. So the one in Houston was extremely well attended. A lot of interest there in these ideas, a lot of good discussion, I thought. And so we've kind of got this going in a direction here. When I made the presentation to GTAC after our November meeting, they asked if we could do a survey of the EMS stakeholders to see if they had some value, if they thought this was as valuable as we do, and that we've been working on it. I've got the survey put together. It has not been distributed widely yet. I'm hoping to start that this week, and we can see what those results are by our next interim meeting, and then share them with everybody in May. Because their concern was that we might be working on this, and then the stakeholders are all revolt and say some of these ideas are horrible. Why, this would just be a waste of our time. So to avoid that time wastage, and I had a little concern about that myself moving forward until we went to the meeting in Houston, and I told a couple of people that were at the Dallas meeting that couldn't come to the Houston meeting that not only did the large majority of the people in attendance there like a lot of these ideas, I kind of felt like that we as a committee were reining them back a little bit, because it was almost like we were going to go 0 to 90 in 2.5 seconds, and it was like, whoa, we can't require everybody to have a 4-year EMS administrator degree. We need to pull that back just a little bit. So it appeared, from that group, it appeared there was a lot of interest. Because of the issues going on in the Houston area, that kind of makes sense. So I'm going to present, we'll get the survey out, and it'll be coming, and we can see how people feel about that. The nice thing about my total dropping the ball and getting that survey out before now is that we have the ability to survey on where the ideas are solidifying on these 7 ideas for combating fraud. So the first one was the increased requirements on the administrator of record. Where are we at here? So I've put down some notes here that I want to read, that this is where we're seeing some consensus being built. First is there should be qualifications on the position. There needs to be a class that folks need to attend to achieve this administrator of record title. Some of the things to add to the rule is that the person that is that for an agency needs to be accountable, needs to be held accountable, and their EMS administrator, I'll use the word certification just for the total lack of a better word, their EMS administrator of record certification needs to be tied to them and not to the agency. So if Kevin messes up and leaves the agency and DSHS comes in and does an investigation, they're not going to, if it was your mess up and you were the administrator, so what they're saying, it would come back on you, not on Washington County or Schertz EMS or however that may work. So there needs to be one for each organization, that folks should only be able to be one for one paid organization. If they needed to have a reason to do more than one paid, that could be some type of variance process through DSHS. And I think Lon had that example where there was an EMS administrator near his agency, another paid service that had passed away, and Lon was covering for a period of time until they could recover from that and replace that person. One of the things that came out of Houston was it needs to be Texas specific. Nothing would trump it. Everyone has to have it, and no amount of education or experience would be able to take the place of it. Thoughts on the course itself. New provider license applicants have to have someone who has completed it prior to them being given a provider license, with a variance in place if there was a public safety need. Current EMS administrators of record would have some type of grandfather date. That's ranged anywhere from 1 year to 2 or 3 license periods. So the time frame on that, we've not been able to reach a good consensus on yet from the stakeholders that have been attending the meetings. Minimum of 40-hour class. It needs to be made up with folks from all the regulatory agencies that affect us. So DSHS, for an overall understanding of Chapter 157, the DEA, DPS, OIG, FBI, CMS, HHSC, PQRST, and the rest. The Labor Board, the Texas Medical Board, and to do some of that in segments for the folks that needed to grandfather, but for those who were getting it for the first time, it needed to be one 40-hour, however many hours that turns out to be, class. The thought is right now from the stakeholders is a minimum of 40 hours that would be taught like 2 or 3 times a year. It would not be taught that often. I mentioned about it being tied to the individual, not the agency. And the thought that came out of the group in Houston was that it should be limited to a limited number of groups that teach it. I mean, we could all think DSHS would do that, but they don't have the resources or the funding to be able to do that. But if they were to farm that out, it shouldn't be something that every junior college, every EMS provider, every RAC, whoever that wanted to teach it could be able to teach, because it's going to water down the message, and you're not going to be able to get the right people there, especially for the new providers, to be able to give the message clearly like you would if you have the person coming from HHSC every time. Some things that have not been agreed upon yet that are all over the board is, should the administrator of record have EMS certification of some type? or not? What level in the organization should the administrator of record be? If the agency has multiple operations, how does that affect the administrator of record if there is one provider license or multiple provider licenses? What exactly the job description of EMS administrator would be? So what is it they're going to be responsible for? There's a lot of concern that if you put these requirements on for folks who may not be getting into the business to do things correctly, that they may make that person the sacrificial lamb. They would have absolutely no oversight over the operation at all, and so really couldn't impact the way the thing operated, but would be holding that title. And then is there a number of years of experience necessary, also came up at the Houston meeting, and we didn't reach any conclusion on that. On the geographical limitations and local input, we've really not had too much discussion on that in any of our meetings. Background checks on new provider license applicants, there was some discussion in both locations on that. We've reached consensus, everybody thinks that should be done. We have not reached consensus or really dwelled too far into what would disqualify a provider license applicant. I think the only one that has come up in both meetings is if they have been previously disqualified from being able to seek federal reimbursements, federal or state reimbursement, that they should not qualify for a provider license or an EMS administrator of record, but there's not been anything else that's on that. Performance security or a letter of credit for new EMS transport providers was another suggestion. When we've talked about that, everybody thought that was a good idea for new providers. The compliance plan and compliance CE, everybody's taken that back to the administrator of record. It's really turning out to be, I think, a compliance position more than it is, it's an administrator position, but one of the big things they're going to be charged with is keeping the agency compliant. And so is that something that needs to be separate, or is that something that can be rolled into the EMS administrator job description? The business plan, everybody has felt that would be a good idea for new license applicants. And the post-licensing evaluation, which is the sometime in 0 to 6 months or 0 to 1 year time frame that all new applicants would get re-inspected on an unannounced basis. And I think everybody supports that as well. I do know DSHS supports that. They just currently can't fund that. So, and some of these may end up into funding issues once we take them to GTAC, and if they approve them and turn them over to DSHS, we'll know more about it then. And then the last one was increased accountability on EMS personnel, and this brought up some discussion both from the committee as well as the folks in attendance in Houston about a couple of things that I believe we put into our 157 suggestions, which was that we recommended DSHS develop a discipline manual like their education manual they have for educators, so that EMS operators would know how that process is intended to work. And then there was a discussion of potentially having a peer-involved process in the discipline, and that again is going to be strictly a DSHS question if that's possible or even recommended. So that's still kind of hanging out there, but that did come up in Houston, both of those ideas. So thoughts from the committee on those topics? Is anybody on the committee awake? Okay, good. That's a positive sign. Anything there like, oh my Lord, what are you talking about? You made that up? You dreamed that? Or?
No, it sounds good.
Okay. Thoughts from the audience? People that haven't been able to attend one of these meetings, or maybe this is the first time you're hearing about it, or maybe you've thought about it since we talked about it in November, and you have some other ideas, anything that we can put into our idea pot? Man. Here we go.
It'd be nice to hear their thoughts on whether or not you should be certified as something to be an administrator. That seems to be the biggest point of contention that we're hearing so far.
Yeah, absolutely. Go ahead.
My name is Matthew Baker. I'm the regional administrator for the track V in the Valley.
Okay, cool.
And this is probably not pertaining necessarily to your question, but I'm just wondering, are you the certification body for EMS companies? Is there a standard across the board that you have to meet a minimum standard to get certified to be an EMS company at all?
DSHS is the regulatory agency.
Okay.
And they have a set of standards laid out in Chapter 157 of the Administrative Code. Chapter 157.11, I believe, is what, and then that'll lead you to some other sections.
Who enforces that?
The Department of State Health Services. See those guys sitting right over there?
Okay, all right, thanks.
Is there something we can help with, or do you have some concern? I wouldn't, if you know of some violations you've committed, I wouldn't necessarily bring those up here.
No. We have, and of course, coming from Hidalgo County and Cameron County, these types of things, we have a lot of EMS providers, and I just didn't know if there was a standard, across the board that these people have to comply with to be part of something, part of a group, part of an organization, to make sure that their policies and procedures are being followed accordingly.
There is, and I'm actually glad you came up to the mic, because I'll tell you, everybody talks about Harris County and Houston, and I think part of that is because the Houston Chronicle has published several articles on this. But those of us who have friends and family and compadres that know people that run operations in the valley know that the problems down there is as bad, and it's just not getting the press that it's getting up in the Houston area. So
there's probably somewhere between almost 40 and 60 different companies down there.
Yeah.
For one county.
One thing you may want to do is the gentleman on the end of the row in the blue shirt is Fernando Posada. That's part of his responsibility here in the state of Texas is the Valley, and you may want to spend a little time. He may have some things he can share with you, and maybe some suggestions when you see things. He might. It'd be good to share your thoughts with what you've seen, and allow him to explain kind of what he would like from you if you see things that are not appropriate and how you go about reporting those and getting those addressed.
Okay.
Who did you say you were?
Who am I?
Yes.
I'm Matthew Baker. I'm the new regional administrator for the track.
For how long?
Since Monday the 11th.
Welcome.
No, it's either welcome or my condolences.
I think your question is exactly what we're trying to fix.
Okay.
Yeah.
By creating this.
Now, and of course, my background is I worked as emergency management for a hospital for 4 years. So
Okay.
I was familiar with the RAC and familiar with the HPP and all these types of things. And, I know the EMS is a real challenge.
Yes.
So that's something, as now being in this role, I have an opportunity to hopefully correct some of those.
Yeah, and I would encourage you to get with Fernando and spend some time. He can get you up to speed on a lot of things, and he could probably recommend some folks down there in the valley for you to maybe go to lunch with, and some of the folks who are really working to do it right and are trying to achieve the same goals you're trying to achieve. And that may help you as well, because you'll know who your friends and compadres are down there that can help with this. I mean, it's a big problem,
Yeah.
and so welcome to the world of drinking through a fire hose, by the way.
And thank you so much for your concern.
Yeah, that's the very reason we're doing this topic.
Anybody else? So what's the feeling of the room on this? Are we on the right track? If you think we're on the right track, raise your hand. If you think we're on the wrong track, raise your hand. All right, come on, Brian. Pardon me, sir. Mr.
Brian.
Norris.
How are you, sir? You don't have to call me Mr. Brian Norris, San Antonio Fires. I was just wondering if there had been any developments or discussions that have taken place since the last meeting that we had last month we had talked about what the qualifications were going to be an EMS administrator. We also talked about which ones we wanted to be the EMS administrator instead of making it like a compliance officer.
Yeah.
There was going to be wording in there, and we were also going to work towards a job description of what responsibilities that person was going to have. Has there been any developments as far as that goes?
No, I put those down as things we hadn't come to an agreement on yet, and I hope to when we get together, when we pick an interim date between now and our meetings in May, that we're going to tackle we're going to spend time on the things that we've not reached consensus on yet. And hopefully the survey will help guide us in that direction too, so.
Okay.
Anybody else? Come on, Aaron.
I'm Aaron Patterson. I'm going to say I'm representing myself. Just to point out in the definitions, emergency medical service administrator in the current rule says the principal executive manager of an emergency medical service organization who is responsible for the non-medical operations, staffing, policies and procedures, and overall management of the service. So just keep that in mind. If you do a certification, you may need to change the definition.
Okay. Thank you, sir. Do you want to come on?
Good afternoon. Chris Alexander, San Marcos Hayes County EMS. To your question about do you need to be certified? Yes. As a relatively new transplant to Texas, do you need to be certified in Texas? I'll debate that with you. But coming in with a Kansas paramedic certification, doesn't make me unable to do the job. But I do think they need to be certified. To the overall picture that you're looking at in Houston, we had one of your friends from Houston come to Kansas City and try to do the same type of operation. And I don't know if you've addressed it in some of the planning to address this or not. In Kansas City, we required that they participate in our regional medical communication system. They had to participate in our regional mass casualty plan. And both of those required some financial outlay on their part because those plans and systems are already in place and they had to buy into those systems. The provider stuck around for about 6 weeks and they were gone. No matter how many people you have to be able to count on them in a disaster type environment where a lot of these folks just keep wanting to run the cheap calls and be done with it. With a requirement like that, it seems to keep some of that to a minimum, at least in our experience up in Kansas City.
All right. Welcome to Texas, by the way.
Thank you.
Chris, what?
Chris Alexander.
Alexander. San Marcos, Hayes County EMS. All righty. Anybody else? Any other thoughts, feelings? Want to throw something heavy? Throw it that way. All righty. We'll select an interim date, and we'll need to pick a location for that as well. We'll do that at the end of the meeting if you guys want to start looking at your calendars. We could go to Ozona. Eddie's not here, so we could just meet at his house. We could go to Spearman, but I hear it's a little tough getting in and out currently.
Don't have much food.
Yeah, there's no food in the Piggly Wiggly because they got snowed in. By the way, Justin's excuse for ever missing another meeting is gone. He calls me up. I got 19-foot snow drifts outside my back door. I don't know if I'm going to be able to make it. I'm just saying, if you can make it here through a 19-foot snowdrift, there is no excuse for you not coming again. I'm just telling you. Dedication. It is dedication. Alrighty, next is our agenda item to select somebody to represent us on the Trauma Systems Committee Registry Work Group. When we met in Houston, we didn't have a quorum, so we couldn't approve that, but we did have somebody that got volunteered. Mr. Petrilla has agreed to do that if nobody else is interested. Okay. We need a motion to make that official for us.
So move.
All right. All in favor say aye.
Aye.
Anybody opposed?
Stay.
All right. Brian asked me if he was still the one doing that, and I said, I haven't seen anybody really wanting to do it for you. All right. EMS for Children update. Dr. Shaw?
Hi. Manish Shaw. I'm the program director for the EMSC State Partnership in Texas. As Dudley had mentioned earlier, our program manager, Tony Gilchrist, he took a new position as the EMS program manager for the EMSC National Resource Center in Washington, D.C., so we're very proud of him that he was selected to represent EMSC on a national level. We'll have a new program manager to introduce to you at the May meeting. So I'm going to provide the updates for the EMSC program for today. A few things that we have going on right now. We are participating in the National Pediatric Readiness Project. This is a nationwide assessment of emergency department preparedness to handle pediatrics and pediatric patients. And so we are in the process of collecting data from hospitals on those assessments. We have about a 33% response rate so far. This assessment closes at the end of March, and so we're hoping to increase that. So I'll be talking with our RAC chairs at the next meeting about ways to reach out to hospitals on a regional level to encourage completion of the assessment. One thing that I did want to bring up here at this meeting is something new that we have available or will have available soon in the next few weeks on our Texas EMSC website, which is a pediatric protocol resource tool. I brought this up at both the pediatrics meeting. They didn't have a quorum, so they couldn't endorse it, but the medical directors endorsed this tool. This is a tool that we have created in response to feedback we received from our stakeholders in the state to provide guidance for EMS agencies to integrate the needs of children in pre-hospital protocols. And so the way that we are doing that is we have 3 things that we're posting on this tool. One is actual evidence-based guidelines that we've created. We have one that we've created and implemented. It's a pediatric respiratory distress protocol. It's been implemented in the Houston Fire Department, in City of Austin, Travis County EMS, and Biotel EMS in Dallas. And so it will be posted publicly for people to view and incorporate as they choose in their own EMS agencies through this resource that will be available in the next few weeks. In addition, we've created 4 evidence summaries on cervical spine immobilization, post-resuscitation care of children, non-transport issues, and non-traumatic shock management in pediatric patients. And so what we've done with these evidence summaries is when there isn't enough evidence to actually create a full guideline or protocol, we've tried to address questions that are of interest to our stakeholders. So about a year ago, we asked all of you for input on the questions that we should address when making these. And so we narrowed it down to 3 or 4 per topic. We looked up the evidence for it, summarized it, made recommendations. And so we will post that on our website. And I believe that Tony had sent that, Dudley, to you to disseminate to your committee to view. And if you've had a chance to do that, we would welcome your endorsement as well if you've had a chance to review it. The third thing that we're going to post on this tool is other resources that are available for guidelines to guide you in the process of guidelines creation. And so there are several projects that are going on nationally that once they're published, we can post. So one is the creation of a pediatric seizure guideline for pre-hospital care. The second is pain management, and third is use of helicopter EMS. These are all projects that were funded by National Highway Traffic Safety Administration and in partnership with the EMSC program on a national level. I participated in the seizure guideline creation. These will be published as a group, and they've been submitted for publication in pre-hospital emergency care. It's expected they will be published in September. Once they're published, we can reference those as resources. And in addition, I represent the American Academy of Pediatrics on a national initiative through the National Association of State EMS Officials, funded by the National Highway Traffic Safety Administration to create model EMS guidelines. And so both I and Brian Moore, who's the State Medical Director of New Mexico, who's also a pediatric emergency medicine physician, the 2 of us are representing the needs of children on this project, along with the rest of the work group. And we expect that project will be done sometime in the summer of 2014. Once that's published, that will also be a resource that we could reference on our Texas EMSC website as well. So these are resources that we're hoping will be available in the next few weeks on our website once it goes live for public use for EMS agencies and medical directors to use as they choose based on the individual considerations of their EMS agency for how they plan to incorporate them if they want to. So that's an update on that, on the protocol resource. I wanted to give you another update. We've brought up issues regarding ambulance equipment in the past, and so I wanted to give you a thank you for the feedback that you've given us in the past. The ambulance, recommended ambulance equipment document that is endorsed by ACEP, AAP, and AMSP, EMSC, and the American College of Surgeons, it gets periodically reviewed, and so it's up for review. I've participated to represent the AAP in updating it, and the feedback that we've received here in Texas has been very valuable to ensure that the needs of the end users are incorporated when lists like this are made, even if they're not adopted on a statewide level. And there are other states who do, and there are implications, as we've learned from your feedback, when doing that. And so we've made sure, both Tony and I have made sure that those interests are represented in the current revision, which will be published later on this year in pre-hospital emergency care as well. Examples of that are making sure that equipment that's listed on there is in accordance with the most up-to-date science. So, for example, meconium aspirators are no longer recommended for neonatal resuscitation, so we requested those be removed. Things that potentially cause harm, like traction splints, we asked those to be removed as well because there are reports that those can be harmful. Things that are not used by a certain provider group, for example, length-based tapes have equipment and medication dosing, which may not be as relevant to a BLS provider, but more relevant for an ALS provider. We asked that that be moved from the BLS list to the ALS list. And certain agencies may not have it in the scope of practice for their providers to intubate children. And so if it's not within their scope of practice, then things that don't fall in line with the scope of practice for their providers shouldn't be put on the list as well. And so we've recommended those things, and most of those things have been incorporated into what will be the new version for 2013. So I wanted to reiterate our thanks to you for the feedback that you've given us, because I think that that feedback needs to be represented on a national level, because there are other states like ours that do not choose to adopt the list, and I think that the needs of those stakeholders need to be incorporated on a national level as well. So I do thank you for that. And so as a segue, when we're talking about ambulance equipment, we are due for another assessment on a statewide level. We do these assessments periodically, and so our next assessment of both ambulance equipment and online and offline medical direction for EMS agencies in the state is coming up July, August, and September of 2013. So once again, we encourage all of your EMS agencies, if chosen to respond to the assessment, since we have so many agencies in the state, we choose to sample them on a geographic basis to make sure that they're geographically represented and that the ALS and BLS levels of care are also adequately and proportionally represented in the sample that we use. And so if your EMS agency is selected to respond to the assessment, we encourage you to participate in that, and also in the coming months we'll be updating our database to make sure that we have accurate contact information for your EMS agency. So we also encourage you to respond to those requests so that we make sure that we have adequate contact information as well. So that is all I have for our updates for EMSC. Do you have any questions for me?
Who is on the protocol resource work group?
The protocol resource work group. So our staff consists of our program manager, which has been that seat is currently vacated, and myself as the program director, as well as our new cycle of grant funding starts on Friday. And so we've also brought on an injury prevention specialist, a disaster preparedness specialist, and a quality improvement specialist, as well as we also have a network of family advocates who participate as well. In terms of who was responsible for creating the different resources that we plan to post for the pediatric respiratory distress guideline, that was a joint project that was grant funded where we had the medical director from each of the three systems that I mentioned, from Houston, Dallas, and Austin. We had a paramedic from each system, and we had a pediatric emergency medicine physician from each system, as well as one parent. So those 10 people were involved in the creation of that project, and so we had buy-in at the beginning from the medical director to utilize the guideline once it was created.
Yeah, my suggestion would just be to add a rural
A rural.
director to that. It sounds like you have an urban kind
Right. Yeah, that's excellent feedback. That project was initially designed with those three systems in mind, but for the other stuff that we do for creating evidence summaries, absolutely, I think incorporating the needs of the rural agencies will be important, especially with this NSEMSO project that I'm working on. As we start to create drafts of guidelines, I definitely want to bring it back to this group at GTAC to get feedback. And if you have recommendations about ways to do that, we plan to do that through RAC chairs and through medical directors, pediatrics, and EMS committees of GTAC. If you have other suggestions, I welcome those as well. Mm-hmm.
Anything else? All right, Doc, appreciate it.
Sure, thank you.
Thank you for your report. Next on our agenda is the Chapter 157 updates and the work we did, make, turn in rule suggestions. And I know nobody else has asked this, Jane, but sometime between, I know it was like something, what's going on here in Austin? It seems really crowded. A lot of people around acting crazy.
You know, I just don't know. I don't know what's
okay.
happening in Austin. But
There's another Formula One race, maybe? Is that what it is?
yeah, that's pretty much the way it feels. Okay. You know, we'd probably be through if Mr. Bishop was going to stay with us, but since he's leaving.
Quitter! I've been waiting all day to say that.
You know, Dudley, we were talking about this, I guess a week or so ago, and I can't give you a good timeline when we're going to have a good draft.
Okay.
Every time we start to work on it, you've heard the expression, the cheese gets moved. We have other people directing what we do on a daily basis now, and they seem to take priority. So as soon as we get over some of the, I think the bill cutoff for filing is March the 8th. So hopefully things will settle down a little bit after that, and we can focus more on it. We've made some real good progress, both in the EMS side and in the trauma side, but we're nowhere near having a draft for you guys to look at. I did visit with Jory last week and spent some time with her to go over just what we've done on 125 so far, and to kind of get some feedback and let her know where we were. And we'll be doing the same with the rest of the committee chairs. We just kind of have to pick and choose when we can. Okay.
Appreciate it.
Sure.
Any questions for Jane? All right. And Maxie, congratulations on that, by the way. I didn't mean to, call you a quitter and everything without at least saying good job, but congratulations.
Good job.
I know.
Good job.
And I called you. I called you a quitter before you actually have left, which means there's still some time you could ineffectively. Yeah. And I know because when you stop by on Christmas Day, you know where we are. So anyway, we talked about that. The other thing we need to talk about is and I think they're looking for a little support on this, but medical directors developed a position paper regarding education programs and the medical director's responsibility for that clinical care that's provided by EMS students when they're riding on EMS transport provider vehicles. And the medical directors have a position that they would like to see that addressed, where not only do our agency have to sign that clinical affiliation agreement, but our medical direction has to agree to that clinical affiliation agreement, where it outlines what level of care they can provide and all those other things like that. And I wanted to bring that here just to give you guys a chance to talk about that. I think the Education Committee supported it this morning. It came from the medical director, so of course they're 100% behind it, but I wanted to give you guys a chance to discuss that, and the group here, if they haven't been in the meetings this morning, a chance to weigh in on that if they want to.
I think it's a good idea.
Okay. Anybody else?
Well, I think that some of that seems to be covered in the new
You're
rules.
talking to the mic there, Kevin.
I'm
Sorry.
just saying some of that seems to be maybe covered in their, the rule that Dr. Greenberg just spoke about.
In the 197?
I mean, you can read some into that, I guess, and some of that's covered there already. The only reason I say I think it's a good idea is I think it's a good idea for them to understand, and some of the medical directors may not understand your affiliations. I don't know if it's on or not. I don't feel like I'm yelling at myself.
Talk a little bit louder. Get a little closer to it. Pretend you like it.
Yeah. Okay. Thank you. I don't understand if the medical directors all understand when a provider may affiliate with another hospital to do clinical internships. They may not even know who they're affiliated with. So that's my point of view on it.
And I think one of the other things that some of the medical directors brought up was that they're not absolutely certain who is riding on their vehicles, on the vehicles they're responsible for. And then, you may, as the director in Washington County, sign off that paramedic students could intubate on your ambulance, and your medical director may not be comfortable with that. So, it's that type of thing that, they need to have some buy-in and agreement, because they're going to be, by the TMB, they're going to be held responsible. So.
Yeah.
Yes, Ms. Tammy.
I certainly agree it's good for the medical directors to be informed on who's riding out on the rescues, where clinicals are being done. I kind of got different when I spoke with Jody asking some questions about it. He, though, seemed to indicate that it wouldn't be an actual signature on the agreement between the two, where I believe the medical directors are wanting it as an actual signature on the agreement between the two agencies. My only concern with that is we've got a contract for medical direction, probably school has a contract for medical direction, so you're talking about 4 separate entities now that all have to sign this one agreement.
Right.
It's hard enough to get anything far through our city attorneys with just 2 agencies, much less now 4. And how are you going to play all that out now? Where's the liability going to be? Who's going to take what liability? Is all that going to be outlined? I mean, I think it's going to really, really complicate things. From the education committee, to them, it was just more of a somehow documenting that the medical directors are informed of what's going on, which is very easy. I think the medical directors are wanting it much more formalized. My only fear is once you start getting into that and as you start writing out liabilities, and if it makes it too difficult, I can tell you just, from our perspective, there's a good chance the city's going to go, you know what, just forget it. The only one who rides out with us are our members, and we're not going to have anyone else ride out because it gets too complicated. So that's my only concern. I agree totally with what they're going for, and I understand exactly why they're wanting to do this. I think we have to be real careful, because if you make it too complicated, you're going to have some agencies that are just going to go, forget it, it's just not worth it.
Anybody else? Anybody from the audience have any comments? And are y'all looking for support from us on that? I think they are. I think y'all are.
Hi, my name is Fern Walker, and I'm from Texas EMS out in Granbury. I just had a quick question. Was the intent of this, I believe it's just so that the students have coverage, and that so that the medical directors know who is responsible for those. What happens when the students are at the hospitals? Who's going to sign that? The medical director of the department? The medical director up in ICU? I mean, I don't know. I mean, I think there's another question that needs to be looked at and answered there too. And I realize this probably needs to go back to the medical directors group, but just some thoughts before we endorse a whole lot of stuff before it goes back.
Dr. Moore.
As one of the medical directors, I don't really care what the hospitals are worried about. I'm the medical director for the EMS system, and under our state law, it's a delegated authority. It comes from me as the medical director of the EMS system. So we just want to make sure it's clear that when the student's on our truck, that our protocols reign. It's never anybody else's protocols. It's never the medical director of the training program. That's different. You can't have 2 captains to 1 ship. So it's just really a clarification of that. And if we're going to agree between the training program and the medical director of the EMS system, that needs to be clear from the very beginning. If it's complicated then, think about how much more complicated it'll be if there's a lawsuit. And now we're trying to figure out who really is responsible. If we go into it all agreeing that you're going to follow my protocol on my trucks and do it my way. Now, when you go to the hospital, you're going to be under whatever department head you're under. That's a different problem. We're not worried about that. We just want to make sure it's clear that there's one medical director per EMS system, and that has to be those protocols you follow.
Thanks, Dr. Moore. And they handed me I was looking for it here on the internet, but they handed me the actual position. Here's the 3 bullet points from the medical directors. They're seeking approval of a position that, while functioning within an EMS system, all practicing providers and students fall under the authority of the EMS system medical director. The affiliation agreement between an EMS system and a training program should reflect the authority of the EMS medical director for all care provided. And DSHS should add a requirement to program approval regulations that requires the EMS system medical director approval on any affiliation agreements between EMS systems and training programs. So this is merely for the ride time as students on a Texas licensed EMS transport provider. That system's medical director needs to be involved in the development of and the approval of that affiliation agreement. It's not having to do with the program's affiliation agreements. It has to do with the actual transport provider and our medical director approval of that agreement. So that our medical directors are in the know as to what it is those students are going to be doing on the trucks supervised by the personnel that he or she are responsible for. Does that help clarify?
It does.
Any other thoughts, concerns? Yes? Oop. Oh. Yeah, I'll leave it show.
Dudley, has this been a problem? What
I
are we
know.
fixing? Has there been occurrences of a student trumping the medical director? Or what's happened that got us here today?
I think it would,
Dr. Manifold, would you like to talk about that, or Dr. Moore, either one of you? I mean,
I know a little of the history, but I think several of us may be getting those questions.
Sure. From my understanding and from my personal experience, Craig Manifold, San Antonio, one of my personal experiences, services that have entered into training agreements without our knowledge as medical director of the awareness that those institutions were having students rotate on our ambulances, on our services. And so this is an attempt to just incorporate the communications in a formal manner to allow us that awareness and knowledge for these providers who are have practice of medicine under our delegated practice piece. And so that communication is critically important. Unfortunately, it hasn't been adapted previously, and so that's why it's becoming a more formalized process or request at this point in time, I think. So.
Let me ask you a question. Because again, I'm just trying to make it so that our city attorneys don't go crazy. Because I agree with the intent of it. Is it possible that, the agreement, because to try to make it more doable, we created one generic agreement that will then go out to everyone who wants to ride on our rescues. And if it has in there that any student on one of our ambulances must follow, for us it's by telling Dr. Pepe's guidelines when they're on our rescue, would that work to meet the needs, or does it actually have to have, because my concern is just if you say it has to have the medical director's signature on there, you're now just involving someone we've contracted with into the agreement, and it's just going to make it more concerning for our attorney. So is there a way that as long as we have that wording in there, that they must abide by the guidelines of our medical director?
I think that's the reason why we're here at this point, is that hasn't happened, that hasn't occurred, and is certainly not uniform throughout the state. And so this is an opportunity to provide that decrease in variation. I certainly feel the pain of multiple attorney processes and things that go along with that, but we're an important stakeholder in that agreement, and unfortunately there is not always the communication that goes with the medical director when we essentially have a significant amount of the liability and responsibility that goes with that. As a training medical director from a training program as well, I think it's just good communication and coordination, and would allow me from the training side of things to ensure that we're getting the product that we want out of those rotations as well. And so there's, again, coordination, communication, and the formal way to do that, because unfortunately the informal process hasn't worked up till today. So. And I think there's some issue about the administrative burden as well. I've heard about if a medical director changes, then how do you go about getting those signatures? We talked a little bit about that in the medical directors committee. There are legal methods in your terms of agreements that you can put that so it serves through the process that just with the medical director changeover, that there are legal ways. I'm not smart enough to give advice on that, but there are mechanisms like with any other agreement. If the principal parties change from an organization, that agreement can still continue. So I don't think that's a significant concern for us as well. Does that address? Nobody wants the attorneys to have to run through secondary and tertiary means, but I think from the medical director perspective is we're trying to minimize that variation and make sure that those agreements are there. And unfortunately, it hasn't worked in the method or manner that you've described up to this point.
I'm just wondering maybe if it could be a separate agreement between medical direction and their provider. In other words, if I want, school X to come to allow school X to come right out, then there has to be a signed agreement with my medical director saying that that's allowed, and then still the normal agreement between us and school X, so that the two are still kept separate.
But we're partners in that piece as an EMS agency and an EMS medical director for those individuals that are coming through. So even though it adds a step of complexity, I'm not sure that would it would probably take some more discussion to help try and ferret that out, whether that would meet the agreements or not, to be honest with you. So, thank you.
Anybody else?
Russell Weaver with Northeast Texas Regional Advisory Council. Just to clarify, we're only talking about the clinical issues with this, with the actual medical care. We're not doing with anything with administrative stuff, like if the student falls out of the back of the ambulance, breaks his leg, he's still under the student's insurance with the school, things like that, needle sticks, all that
Absolutely.
stuff.
I mean, that needs to be spelled out in those affiliation agreements. All the medical directors are asking for is that recognition that it falls underneath them when they're riding on the ambulance. The EMS medical director has responsibility for all care, so if Kevin's medical director doesn't want him given nitro, then students can't give nitro on his ambulance regardless of what their program tells them.
So we're just strictly doing clinical.
And then lastly, it needs to be reflected in the affiliation agreement in some form.
Just wanted to clarify because we're having some of those questions.
Absolutely. I think that's wise. I mean, right, wrong, or indifferent the way, and a little compassion for our medical director colleagues, but the way most medical directors figure out that what students are doing on the trucks in this state is I don't want to say most, a number of medical directors find out is when the student doing that has done something wrong. And the medical director's like, we were having them do what? And so, one of the things I've often gotten physicians wanting to throw heavy things at me when I remind them that, a lot of times medical directors work for the EMS administrator, but that puts a lot of onus on us. We talked about that with the Rule 197 stuff, that you can walk around and say that, but you now own the responsibility of protecting that individual and their medical license. This is, I think, a critical part of that, and I agree with Tammy. It's going to be hard, especially for agencies that have contracted medical direction and not employees that are medical directors. So I think it's going to add a new level of complexity to it. But I also think once we get it done once or twice, then it'll be done. And what works in Dallas may not work in San Antonio or Schertz or Washington County either. So,
Dudley, what are you looking for? Are you looking for a motion to support that statement?
yeah, I think if there's no more public comment, I would ask the committee if you want to support the. Oh, come on up.
David Allman from South Taylor EMS. Sitting through some of these meetings today, thought about why not put this on the administrators and the providers instead of the clinical companies. Why not, when you renew your provider license, your medical director marks on there whether or not they want students on their trucks and which ones they want to affiliate with, instead of having to have one for every deal. We send in personnel lists every time we update to DSHS. That why not make a affiliation list that our medical director approves with his signature on it, and that's part of our renewal. They're seeking a rule. They want a rule. So my opinion is, instead of putting that on the training programs, do it on the providers.
Thoughts?
Maxie, isn't that already isn't the clinical agreements that we have to have in place, isn't that done per class, per course number? Per program? So could that be a biannual thing? That's what he's asking. That's my understanding. He's asking for a biannual list on the provider licensure.
We're talking two different things here. Most people don't know who their students are at a different time. We're talking students, we're not talking employees. You need to talk to your lawyers about that because it is going to be different. As Tammy said, I guess, depending on the contracts you have with these programs and what have you, it can get very tedious in a sense, but those directors are right. And I think some of the problems that we see on the regulatory side is there are people on those ambulances, and one of your EMS personnel say, well, I got a buddy that needs some hours, and I'm going to let him come ride our ambulance. But the medical director, even the administrator, the owner of the company don't even know that they're out there doing those things. So you all are going to have to talk to y'all attorneys and see what they're telling y'all about this. But I think the directors, medical directors, are trying to protect themselves, and they have a right to do that.
I think everybody agrees that there needs to be better communication between the medical directors and the administrators, and everybody needs to have better communication. My medical director would not have a problem signing off on a list saying these companies are allowed to put students on our trucks. You know, but there's got to be an easier way than have, because I do both. I do a training program and I do EMS provider. So
Can I ask you a question about your training program? Were you in the education committee meeting this morning?
Yes.
Where they made the recommendation that a medical director now has to sign off on training programs as well, the CE program?
Yes, sir.
Were you in support of that?
Yes, sir.
So is there any difference really in what we're talking about? We're still working on educational components for clinical rotation, which is training programs.
Sure.
So why would the medical director not want to have a piece of that as well?
And I'm not disagreeing with that. I'm just saying, you know, yes, the medical director needs to be aware of who's on the trucks, but there's an easier way to do that, such as putting that in with our provider renewals, updating our list or something, you know, like we do with our EMS personnel, saying our medical director signatures here, this is the people that he approves to do clinicals at our site. You know, just trying to ease the paperwork problems. I mean, you know, a lot of people don't care about paperwork problems, but we kind of do, so. Thank you.
$275 an hour, I sure care about paperwork problems, but anyway. Anybody else? Anybody else? Bueller?
All right. I'd make a motion that we support the medical directors and their stance on their position paper.
Okay. Justin's made a motion. We support their position on this. Do I have a second?
Second.
From Lucille. All in favor?
Aye.
Oh, we're supposed to talk about that. Anybody opposed? All right. All right. Fantastic. More legal fees. You know, no matter what we do here, there's only one group of people that are ever happy, and it's the attorneys. Somewhere or another, my attorney just racked up another hour of time. Billable hours, that's what it's all about. Let's see. All right, general public comment. First of all, from the committee, does anybody have anything to bring up for the general good of the order?
You skip 5.
Did I skip 5?
You want the update that we...
Oh, I'm so sorry. Yes, I skipped 5. See, I have this line going right past it, and I just followed that line down to 6. Would you like to update us, Mr. Boyd, on the joint ground and air work group regarding patient care issues when you're both on the scene?
We have met. We did formulate some questions. We had a chance to visit with Maxie and got some verbal responses from Maxie that we crafted into written questions that in turn, I don't want them to hear.
Yeah, speak up, man. Get closer.
So we did ask some questions of Maxie. We did meet. Maxie was able to attend kind of a short question and answer session for us last time. We've then since put those questions in writing, and we're going to formally send those to the state for a in writing type of response. So we've also been told that now Maxie's leaving, so we're going to have to send that to the next person. We're not sure who. I know that it's a agenda item tomorrow for our medical committee as well. So we're waiting on a formal response from the state, but it's still moving forward.
Okay. Any questions for Justin on that? All righty. Now, general public comment. Anything from the committee? Did I skip anything else, Justin? All right, good. Anything else from the committee? I've got 2 or 3 things I wanted to bring up, but let's give you all a shot first.
There was discussion today, and maybe we need to address that, and I don't know if this is a proper time, Dudley, but the Education Committee was started having conversation about clinical rotations concerning out-of-state affiliations. I know they're going to be talking about that at length probably coming up, and that probably might be something that we need to have discussion with or about.
Okay. Education Committee looking at affiliation agreements with out-of-state clinical rotation sites.
Did you hear what their issues were?
I think the issue was brought to them from the El Paso region and also from the Panhandle region where I'm at, is about the length of travel where some of the students are having to travel now, especially since we've gone through accreditation and that whole component. And they actually were asking the state to try to adopt some rules and some language that would support and allow us to do clinical rotations outside the state. Maxie had some thoughts. Do you want to reiterate your thoughts, or? Okay.
Yeah.
Okay, but that was kind of to allow that to happen, or the possibility. There was talk of continuous states or contiguous states, and then there was talk about a mileage restriction on the how far you are from the program or the program's area. So I know the Education Committee is going to set that into their work group meeting and go from there.
Anybody else? Another thing Education's working on, along with medical directors, is looking at asking DSHS to, in the rule change process, to go ahead and start requiring CE programs, those who get CE provider numbers, to have medical director input and involvement in that. That was actually something I took to them after finding one of our first responders had a CE number, and our system medical director had no idea they were teaching CE to their providers or if it was in line with our protocols and that kind of thing. And then we discovered that you don't need, it's the only facet of pre-hospital healthcare you don't need a medical director for, evidently. So I think it's probably an oversight during rules. So just so you're aware of that, we can monitor that discussion. If we need to talk about it at one of our meetings, let me know. We can put it on the agenda to discuss as well. But that really seems more education oriented.
Hey, Dudley, I think did they not have moved to adopt the language that?
Anybody?
Is that in the medical directors or the education?
It was education.
Education moved to approve that and move it forward?
I believe
Okay.
so.
Did medical directors take any action on that today, Dr. Manifold?
I think just to support it.
Okay. And then the other thing that we need to talk about as a committee and see if we can reach some consensus on, it's not on our agenda, but we can, I just want to brief everybody. As you know, in the August through November timeframe, there was some discussion by the GTAC Council about changing meeting times and lengths. And I know there were several of you on this committee that had some concern about that. I put a survey together. It came back and showed various things. We presented that to the GTAC Council at the conference on that Monday evening, had real good discussion, and went back and forth with it, shared some things with them, and I think to their credit, they want to examine that a little more deeply before they make a decision. One of the things that came up in that meeting was that way back somewhere in the GTAC process, there was the development of an executive council of the GTAC Council, which is made up of the chair and vice chair of GTAC itself and the chairs of all of the committees, the standing committees. So Chief Riley went to that in the GTAC rules and had a meeting of the executive committee and to talk about this topic. We met a couple 3 weeks ago. And so what came out of that was he charged the chairs to get their own committee's thoughts as to how long the committees felt, each individual committee felt they needed to get their work done every quarter. Is it 30 minutes, 60 minutes, 90 minutes? I don't know if we should really push past 90 minutes. We could go crazy if we wanted to, but and so I'd like to hear the thoughts of the committee members as to how much time you think we need every quarter to get our work done. guys have to talk now.
Oh, it's yours. This is all you. Here, we'll give you the mic.
Dudley, occasionally we go less than 90 minutes, but for the most part, we can take up 90 minutes and then again some. So I think for us, 90 minutes is a very good time. I know there's some other committees that might be able to do with much less than that, 45 or 60, but for us, I think it's 90.
Okay, thank you.
I agree with
Anybody
her.
else?
I agree.
90 minutes.
Well, that was a lot easier than I thought it'd be. Alrighty. If there's nothing else from the committee, I'd like to open it up to the floor for any general public comments, anything we've talked about, anything we haven't talked about, anything that we need to be aware of, you want us to talk about or be known?
Dudley,
Yes.
do we need to be, I know Dinah's in the back of the room too. I know that there's some bills floating around that could involve EMS. Do we need to be paying attention to any of those that are being discussed right now?
Now, the legislature has our best interest at heart, and, oh, sorry.
What state are you in?
Sorry, I'm awake now. Dinah, would you like to come share anything on that?
Sorry.
That's all right.
You know it's session when you have your list of bills handy. Yes, there are a number of things floating around, and I think Dudley was talking about a few things earlier. What I would say about EMS right now up at the Capitol is there's a lot of whack-a-mole going on with the whole Medicaid fraud and that kind of thing. And so there's a lot of discussion about that when I'm in offices, public health committee members, as well as health and human services committee members. And I think they're trying to figure out how best to tackle some of those issues. Dudley, I walked in when you were talking earlier about the administrator of record. Were you discussing that regarding legislation or just some of the things that y'all were?
Just some of the work we've been doing on some ideas that were presented that Kathy sent to us to try to develop some real recommendations off of.
Because that is one, I know that some of those ideas are being floated around the Capitol. There has not been any legislation specifically filed that deal with any of that at this point in time. But there's the bills that have been filed by Representative Richard Raymond that have to do with certificate of need for EMS providers. And I can give you the bill numbers. House Bill 975 and House Bill 1342. There are several bills dealing with vehicles, definition of authorized emergency vehicle. I won't go through all those specifically. House Bill 365 by Representative Martinez. If you are an EMT or firefighter and you have a stroke or cardiac event, it can be deemed a on-the-job illness, or so there are benefits to the EMT or firefighter if that were to occur. Interesting one I'm sure will be discussed at some point in time is there's House Bill 409 by Phil King that would make it that the GTAC EMS medical director would become the state EMS medical director, but there's not a lot of meat to that bill as far as what does that mean? Is that a hired position? Is that a state? I mean, is it just sort of a name only kind of thing? But be interested to hear sort of the feedback on that. Senate Bill 53, Zaffarini's bill that I know the Ambulance Association has been working on closely, and just defining sort of the life support services provided by EMS. Another one that I know the Ambulance Association is following pretty closely, and actually, I think worked with Representative Kemple to file is House Bill 521, which would direct that payments from insurers would be paid directly to EMS providers instead of going to the insured. The problem being, obviously, that a lot of times those monies go to the insured and they never get to the EMS provider. So I think that's a good piece of legislation. There are several bills out there dealing with repealing the driver responsibility program. Yesterday we had our EMS and Trauma Day at the Capitol, and one of the press people was talking to me about driver responsibility program. We always try to really just focus on the funding and how important the funding is, but everybody wants to discuss driver responsibility program. And I don't think anybody's against trauma and emergency health care funding. I don't think that's the heart of why they want to repeal the driver responsibility program. They feel like the program is double jeopardy. Some of them feel like it's unconstitutional. They also make claims that when the legislation was going through back in 2003, that we were actually arguing that by creating the program that we would reduce the number of DUIs, people driving intoxicated. Sort of interesting in this day and age. I was actually standing in the back looking at the bill analysis from 10 years ago, and it does not say that. It talks about having bad drivers pay into the program, but there are a few of those bills. I would say that those that are against the driver responsibility program, they are probably becoming more passionate, more outspoken. Representative Larry Gonzalez has filed a bill, and that bill number is House Bill 104. There's a couple sponsors, co-authors on that, and then House Bill 790 by Sylvester Turner. And I understand from a conversation that a couple of our trauma people had yesterday with Senator Watson is that he plans on filing a similar bill to do away with the program. And then there's a number of bills, there always are, but dealing with blood specimen collection. And it seems like, and Dudley, I know you've been around for this fight, but it seems like there's more bills this session dealing with the collection of blood specimens and sort of expanding who can do that.
I think the Supreme Court's going to line that out for us here pretty soon.
Yeah. I think that's sort of the high points. I know there are a number of other things on my list. Dudley, I know you're very involved. Anything else that you can think of that I've left off?
Senate Bill 53 that Donna talked about is a request to change the definition of ALS. It was filed. A lot of people had concern with the language. The language has since been changed to keep the current definition of ALS and BLS just like you see it, but on the definition of ALS to add a phrase that says which includes an ALS patient assessment. And the whole purpose of that is to try to head off a move by HHSC to change the requirements for ALS 1 emergency calls to be billed differently in Texas than they are for Medicare. It's not because they want to do that, it's because in an audit, the Texas definition of ALS is more restrictive than the federal definition, and the OIG told them they needed to pay by the more restrictive definition. And so when you go out on an emergency call to a call you believe you should send paramedics to, and you perform an ALS assessment and you can bill for that at ALS 1 for Medicare, if the language doesn't get changed here in Texas, you won't be able to bill that way here in Texas. The biggest area of concern on that one is on Medicaid crossovers, where you bill Medicare based on your ALS assessment appropriately. They pay it, it automatically comes to Medicaid. Medicaid would automatically pay the 20% copay because there is no way to signify that you're billing ALS 1 to Medicare based only upon the ALS assessment. When Medicaid would pay that to you, you would then have to turn around and refund that money back to Medicaid to prevent yourself from being in a fraudulent situation with them. So that is the reason behind that bill in specifics. It has been heard in committee and voted out to the full Senate. So hopefully that bill will continue. That's kind of a big one. For those who've been following the blood draw, Dinah's absolutely right. House Bill 434 is Debbie Riddle's bill. She's the one that met with a bunch of EMS stakeholders and developed a bill that basically says if you want to draw blood on potentially drunk people at the request of a law enforcement officer, your agency has to opt in to do that. So you have to have a protocol, your medical director has to sign off on it, and the medic has the say about whether or not it's going to interfere with patient care and whether or not they want to do it, and that's all outlined in the protocol. This is the third time she's attempted this bill with the same language, so we'll see. Maybe third time's the charm. Not only is there House Bill 521 by Kemple that talks about payments having to come to EMS, that's strictly aimed at auto insurance providers. There's also one, House Bill 522, also by Kemple, that is aimed at health insurance providers, who there's been an increase in them sending payments to the patient and not to the EMS provider. A couple of the other ones that were interesting, House Bill 395 by Larson out of San Antonio. That was a bill that was put forward to give hospitals and healthcare providers, and then they listed out, which includes, and had a list of healthcare providers there, the ability to scan the mag stripe on a Texas driver's license and get that information for your patient demographics. I didn't realize this until I asked some questions, but unless you are specifically given approval to do that, it is illegal to scan that mag stripe on the back of a driver's license in Texas. Despite the fact that there are billing companies in Texas having the EMS provider scan it already, we are not allowed to. Larson's office and the other folks with that bill have added EMTs and paramedics to the list of healthcare providers, and that bill seems to be moving along fine as well. And I think that's the big ones.
There's one interesting one, I just found it not too long ago. It's Senate Bill 261. It says related to the instruction of CPR and the use of AEDs in secondary education curriculum. That's pretty cool. I like that. Can we say it again?
I'm sorry?
Senate Bill 261. And I can't pronounce his name. It's Hinojosa.
Hinojosa.
Yeah, I didn't want to mess that up. Relating to the instruction of cardiopulmonary resuscitation and the use of automatic external defibrillators in secondary education curriculum. I like that.
And if you have a TV on to any news program, there's another bill that's out there, and I don't have the House bill number in front of me, but it's from Representative Ken King. There are 4 representatives with the last name of King, by the way. It was filed just this last week, and it would authorize people who volunteer or get paid in emergency services in counties less than 50,000 people. It would allow them to, if they have a CHL, to carry their handgun while they're on duty on the vehicle, fire truck, ambulance, whatever. And then has a whole bunch of other caveats in there. It basically gives you the same permissions that a law enforcement officer has. So you can you can wear it going into churches and schools and other places that the CHL doesn't traditionally allow you to carry your weapon, as long as you're on duty when you're doing it. So there are no caveats to that, by the way, for any type of coordination with their employer. Or medical director. I don't know if it necessarily applies to medical directors. That may be something else that applies to you guys. But yeah, we'll let the attorneys sort that one out. So that was another interesting one that came out this week that kind of surprised some folks. So, yes. Oh, here we go.
I think one other thing that I will add is just with the EMS and Trauma Day at the Capitol yesterday, we were obviously highlighting the funding, and so that continues to be the big issue. We had several, I was involved in several meetings where obviously discussing 5111 and designated trauma facilities, but really trying to highlight RACs and EMS and the percentage that is currently goes to those pots, and with the reduction 2 years ago in the overall fund, and y'all not eligible for any of the matching dollars, that y'all were hit the hardest, or hit harder. And so just making the argument, the continued argument for There's over $200 million in uncompensated trauma care costs by hospitals. $59 million a year is a drop in the bucket for it, while appreciated, is a drop in the bucket, and that still does not factor in the EMS costs, the RAC cost, and any of the physician costs. And so just continuing to highlight that. And yes, they put us in this $59 million box 2 years ago, and it's not okay. I mean, the need is much greater than that. But I think yesterday was very successful. I really appreciate all those that took the time to come to the Capitol. I think we will forever be remembered by the governor for slapping him. Some will remain nameless. When you're in the front row, you don't see any of the fun stuff. But I think it was.
Governor falling down some steps.
Yeah. For those of you that weren't there, somebody slapped the governor as he was walking down the steps, and I think it was accidental. But
in the face, no less. It's not like I caught his arm or his shoulder. I slapped him in the face.
Well, his comment was it almost knocked his toupee off. So.
I did want to add on the gun. 3 of us actually stopped by Representative King's office, and he happened to be there and took the time to speak with us. We did ask that they add language that before they can carry it, especially if they're paid, that there has to be an agreement with their employer that they're allowed to carry it regardless of the fact that the state law says they can. They still have to have the agreement with their employer, and also that they add some language on liability so that the employer's not liable when they accidentally shoot themselves or someone else. So we did ask them to be sure and try to include some language, and he's very open to trying to make those type modifications.
Donna, as always, thank you for your hard work. Really appreciate it.
Well, thank y'all. It's I needed yesterday. Sometimes you get a little beat down, and being around all of you, it certainly infects me once again. And I'm just always so in awe of what you all do, and I mean that sincerely. So thank y'all.
Anything else from the audience or the committee for the general good of the order, public comment? All right. Well, we'll get out of the way and let is the rec chairs meeting in here? All right. No wonder everybody's coming in here and going, man, aren't they done? All right. Well, if there's anything else from the committee, make sure I covered. Oh, we got to set the date for the next meeting. Do we want to do that in here? Do we want to do that via email? What do you want to do?
Email's fine.
Email's fine. We want to shoot for a Friday like we've done in the past. Does anybody want to volunteer a location?
Since we've got so much going on in the valley, so much concern about providers, should we think maybe San Antonio at least, make it a little easier for them to come up?
San Antonio's not in the valley. I mean, I'm just saying.
Well, I understand that, but I'm not volunteering to go very far south.
I don't know, we could meet at South Padre. I hear that's real nice.
There you go. Is that the valley?
All right. I'll tell you what, let me do a little looking around, see what we can find, and talk to our compadres down the valley, see if they'd be willing to come up for that meeting, or if they're willing to host us, maybe we'll go down there. Crying out loud, Texas Taxi goes there. If we set it far enough out. All righty. Well, if that's the case, we'll be done. Thank y'all.